said, comes at a cost. All right, ladies and gentlemen, it is 1:30, and those of you who know how I like to operate, we start on time, and we end early, if possible. All right, it is my great pleasure, if I can figure out how to operate all this stuff, to introduce today's speakers, and something has disappeared. Maybe, there we are.
Here, I'll do it.
Excellent.
Sure.
I can do what I'm supposed to do. This is
Okay.
speak. We are very, very fortunate, I think, today. Can everybody hear me without the mic? Very fortunate today to have two superb nurses, one in the role of a bedside nurse RN, but they both have their master's degrees in science of nursing and neonatal nurse practitioner. So they're well educated. I've worked with both of them. It's been my privilege to work with both of them. Kellie Kainer is currently an assistant clinical director, or house supervisor, I should say, at Texas Children's Hospital. She received a demotion, I think, because I think she'd like to be back in the nursery. It's a whole lot more peaceful. But she received her training, as I said, and has her master's degree. She is an exceptional clinician, as I already stated, and is passionate about empowering parents of high-risk neonates. And she's worked extensively in our Pavilion for Women, which currently has about 6,500 deliveries a year, I think. Mostly high risk, 20% need further levels of care. Jennifer Gallegos trained in Florida and then, came to her senses and came to us at Texas Children in 2008. And she includes her passions, family-centered care, QI, and care of the very low birth weight infant. So without further ado, the floor is theirs.
All right, and I would like to say thank you to Dr. Speer for inviting us to speak today. We are here today to share some information with you about the care of the extremely low birth weight infant and the processes of setting up a small baby nursery and the benefits of that we have experienced at Texas Children's. All right. So, of course, we have objectives for our session, and you can see them there on the screen. So identify key stakeholders during early discussions of a small baby program to help develop specific guidelines to improve consistent care, as well as criteria for admission and graduation from a small baby program. Discuss the importance of incorporating unit-specific outcome data as well as national benchmarks during the planning phase of a small baby program. And then the benefits of one-to-one nursing for our ELBWs and our VLBWs during admission and around extubation, early CPAP, and its effects on our patient outcomes. Jen and I both have no conflicts of interest, and we have nothing to disclose. Just to tell you a little bit about Texas Children's and kind of set the scenario for you. Of course, we are in the Houston Medical Center. We are a 750-bed pediatric and delivery hospital. A couple of towers make up that 750 beds. We do have two satellite campuses on the west and the north side of the city as well. We are a teaching facility associated with Baylor College of Medicine. Our newborn center alone, which is our NICUs, there's actually 3 of them. And we have 173 beds total between those 3 NICUs. So just our vastness can sometimes definitely have its benefits and its challenges. We do have a level 4 NICU that is 76 beds. It is a pod-style NICU. Then we have a level 2 NICU that is 55 beds, pod-style as well. Those are both located in our West Tower, which is our pediatric building. We then opened the Pavilion for Women little over almost 8 years ago now. We have a level 2-3 combo, can be some level 4s. Those are all inborn babies that are there within the pavilion, and we are a private room NICU within that building. So just wanted to share that with you to kind of set up a little bit of background for you. So what exactly is a small baby unit or program, and why is it important to develop one within your facility? Of course, an extremely low birth weight infant is typically defined as a baby less than 1,000 grams, although for most of your small baby units and programs, you go ahead and put a gestational age with that as well. And we went ahead and wrote that at 28 weeks and 0, which is what is out there in the literature as well. A small baby unit or program is a cohort of these extremely low birth weight infants by geography. So they're all put within one area of your NICU. It can be a private room or it can be a pod style. There's actually both out there in the literature, benefits of both. So it can be, if you don't have a private room, don't worry, you can definitely set up a great small baby program. It's definitely cared for by specifically trained multidisciplinary team. And with a little later in our talk, Jen is really going to focus on the education that we put out to all of our staff, our multidisciplinary teams that care for these extremely low birth weight infants. And of course, you want evidence-based standardized guidelines. So you really want to make sure that everybody who touches these extremely low birth weight infants are all doing the same thing, no matter what their background is, no matter where they trained. We're all following the same guidelines, providing the same care. So where should ELBW infants be cared for? Well, I just want to, kind of, because we are a combined NICU and maternal audience here, we definitely want these small babies, these ELBWs, cared for in level 3 or 4 NICUs. Most of the time, these small baby units or programs are set up within those larger NICUs. Maternal transport prior to delivery to a maternity center that has a level 3-4 NICU is preferred. So for those of you that might be practicing in a rural maternity center, it is very important to try your best to get a maternal transport to these larger facilities that can take care of these ELBW infants. The outcomes are better if they are born within the facility that they remain, and that's not a baby transport following. However, we know that these moms can definitely walk in, the baby's already coming out, and there's nothing that we can do in that instance. So of course, transport as soon after delivery if possible. In the meantime, there is an interim period. If you're unable to transport prior to delivery, consult with the OBs and the neonatologist at that larger facility that is your referral center. So of course, in the state of Texas, with our RACs and our maternity and newborn center designations, we should have those referral centers for our rural hospitals. Reach out to them prior to the delivery of the baby just to ensure that you're doing everything that you can do to ensure that you're giving that mom and baby the best outcome, even if they're not born, even if they are born in the rural areas of Texas. So why start a small baby program? Well, preterm birth rate is still increasing in the United States, believe it or not. All right. Despite advances in obstetrical care, the U.S. still has an alarmingly high rate of preterm births. Cited in the literature are factors such as unequal access to maternity care, which we have definitely heard about this morning, and our high poverty rates. The March of Dimes documented the preterm birth rate nearly 10% in 2017. All right, increasing survival rates of our ELBWs. So we definitely have seen an increase in our survival rates. However, I said this in driving our small baby unit at Texas Children's, it's not just about saving their life. It's also about the morbidities that are coming along with caring for the ELBW population. So we need to do more than just save their life and get them to our NICU. We need to improve their overall outcomes, and that's one of the goals of a small baby program. Variation in outcomes and variation in practices amongst providers. So maybe you work in a small facility and only have a couple of neonatologists and they're all doing exactly the same thing, and maybe all of your OBs are doing exactly the same thing. However, a lot of us work in academic facilities where sometimes it can vary based on who's on call for the day or the night or the weekend call, and people have different preferences on, are we going to use high-flow cannula or do we like CPAP better? I know all of you have probably been in those discussions or situations, even though we may not want to admit it. So we definitely want a standardized approach to the care provided to our ELBW infants. All right, implementation of our small baby program at Texas Children's. And I just want to point out, we call it a small baby program. We did have some discussion about whether it's a SBU, a small baby unit, or an SBP. For us, we didn't want a unit within a unit, so we have a program within our unit, but they are, they can be used interchangeably. So when you read in the literature, you'll see a lot of organizations call it a small baby unit, same thing. So unit-specific data and outcomes is one of the first things that you want to do if you want to implement a small baby program, and this is where we started at Texas Children's. You need to think about your own organizational's data and outcomes of your ELBW infants to identify those gaps. And that will help drive exactly what you need to focus on in your small baby program. So maybe a lot of you report to the Vaughn network, maybe some of you don't. That's actually for us where we started, was to pull our past year's Vaughn data on our ELBW infants. That was definitely a way for us to see where we were and then be able to compare it in future years to the successes of our small baby program. So started by pulling our data. Complete a literature search on small baby units and programs to identify what has worked well and what hasn't worked well, just so that you don't repeat some of the same mistakes that other NICUs have already made. There is good literature out there on the benefits of small baby units and programs, and we'll address some of those at the end. You'll be able to see where some of this literature came from. And then you really want to ensure a strong partnership between your medical and your nursing leadership teams. If the two teams aren't going to come together and be able to support each other, it's not going to be a successful unit. So you definitely want a strong partnership within your medical and your nursing. And Jen and I, we were blessed with that partnership when we set this up at Texas Children's. So everybody should write a mission, vision, and value statement when you want to start a program like this. For us at Texas Children's, this was one of the very first things that we did, and this really helped us stay focused on exactly what we wanted to do each time that we got together to make plans for the small baby unit. So maybe every meeting you've ever been in has been super productive. However, probably some of you have had the meetings that maybe weren't as productive. So we kept the mission, vision, and values at the forefront of all of our decisions just to ensure that we were doing the right thing each time we all came together to discuss the small baby unit. So just to tell you about what ours is, but you can write it completely how you want within your organization, our mission is to foster evidence-based care of ELBW infants in a family-centered environment. So definitely wanted to keep our families in the right in the center of this planning for our small baby program. Our vision is to have the best clinical outcomes possible for ELBW infants born in our newborn center, as determined by key performance measures tracked by our Vermont Oxford network. Our values are respect, teamwork, and excellence. We did read these at the beginning of each meeting. Every time even a subcommittee got together, we wanted to keep that at the forefront. However, we went on ahead and wrote a mantra as well, just to say baby first attitude. And if we always put the baby first, we're going to make the right decisions in planning for a program like this. So here's just a little bit of a timeline on what we did. We have a focused program to care for ELBW infants to improve our key outcome measures, which for us was our Vaughn definitions. Our program will focus on preterm infants less than or equal to 28 weeks or less than or equal to 1,000 grams. We actually did go back and forth on the discussion of should this be an and or an or. So you kind of have to think about how you want that definition to stay. We definitely wanted it or, because we wanted those less than 1,000 grams, even if you were 29 weeks, to still be included with our ELBW and our small baby program. And then, of course, our next step was to complete the guidelines and protocols for the program and then host our educational sessions. So I just want to touch a little bit on the one-to-one nurse staffing that we really felt was important within our small baby program. Although the one-to-one nurse staffing was actually something that we implemented before our small baby program actually went live. And there's a lot of research out there on nursing staffing ratios, what's best for the care of the baby at any age. And for some of you as nurse leaders, you know that finances can a lot of times drive how many nurses you get to care for the babies, and the baby's acuity may or may not be the number one thing that you are looking at. So we developed one-to-one nurse staffing. As you all know, there's been a shift in respiratory care. We used to intubate every ELBW infant, and they were tubed for the first couple of weeks of their life. We probably didn't try to wean them too much. We might have a little bit, but extubation really wasn't on the table, nor did we really bring them directly out of the delivery room on CPAP. However, CPAP first is now the driving force behind coming out of the delivery room, and we all know that's the best thing for their lungs and prevention of chronic lung disease. So our CPAP first initiative has driven some of this change, as well as our gentle mechanical ventilation. And of course, as all of you know, at bedside, we want our target saturations for these ELBW infants to be between 90 and 95. However, that can be very hard to maintain on CPAP. It's a lot easier nursing-wise and nursing hours to care for an intubated ELBW than it is a ELBW on CPAP, and be able to keep the pressure no matter what CPAP, if you use bubble CPAP or vent CPAP or what kind of prongs you use. We all know prongs, mask, they're all challenging to keep the right pressure for those tiny babies. So we definitely want to keep our oxygen range within there. So how do we get there? We made the goal to staff the first 72 hours of life, a one-to-one nursing staffing ratio, as well as the first 72 hours of CPAP. Ideally, this is the same first 72 hours because we like to bring them out of the delivery room on CPAP. However, even if we brought them out of the delivery room intubated, we still ensured that there was one-to-one staffing as soon as they were extubated. This has actually driven a nursing research project, and we have definitely seen an improvement in our re-intubation rates based on the staffing ratio. Financially, it took us a little while to get the support within the organization. So some of you are sitting out there thinking, there's no way my organization will ever let me do this. Really drive that data and collect everything you can, because you'll be able to drive home the importance of the one-to-one nursing staffing ratio. Now I'm going to kick it over to Jen. She's going to tell you a little bit about the committees and how we actually implemented our small baby program.
Thank you. So a lot of work that went on behind the scenes was committee formation. And what was very important is that we had a large overarching leadership small baby meeting. And then we kind of divided out the work because we knew this was we wanted to get this up and running, and we didn't want to sit here and have everyone kind of doing the same thing. And so we kind of figured out what was the most important thing, and we divided out into subcommittees, and we gave the expectations and what the structure should be. So the main committees we had were the workflow process, a guidelines committee, education, and then outcomes and compliance, which initially started off kind of as the same committee and has now morphed into two different committees. These committees might vary based on your organization, and this is what we found, what we identified in the gaps and how we could provide this education were the committees we went with. So the first one was the workflow committee. This was one that I had the privilege of being on, and it was intense. And so one of the main things for this workflow, we really wanted to think, what did it mean for a baby to be in a small baby program? We really dug down into the minutia of the who, the what, the when, the where, the how, and why. We wanted to make sure that everyone was keeping in mind the consistency of care. So we had to think about things such as basics. Which part of the unit? Our unit is a big, it's kind of like a big circle, but where should we care for these babies? What's best for the staff, that they're not going to be isolated from everybody else? We had to think about how many beds do we need? So a lot of it, we went back and looked through what our average daily census was from the past 1 to 2 years of babies in this population to kind of figure out, okay, we need about this number of rooms, and then let's think if we have a surge, we need to have a nice pop-off, and it just kind of flows seamlessly. That was one of the first things we had to think about, was where are we going to care for these babies in this program? The next thing we had to kind of talk about was the medical teams. Because we are an academic facility, we have a large variety of trainees. We have residents, we have fellows. And as you know, caring for small babies can be very labor intensive. We had to make sure that we were giving our trainees the proper education, the care for these babies, but not having 10 of them on one team. And so with the variety, we also had to think about how are we going to divide out these babies amongst all 3 care teams that we have, and making sure that we had the optimal distribution of workload in addition to education for the trainees. We had to think about the bedside staff. What kind of staff are going to be involved in this program? We already have a core group of respiratory therapists, and what we wanted is we really wanted some more experienced nurses. And so what we did is we asked nurses to apply to be a part of this program, and so they had to have a 2-year minimum experience. And we had a good amount of nurses apply. All of the current charge nurses were already included, and then of course our neo-response nurses as well. Ancillary staff, because we know these babies, we need help with our PT and our OT colleagues in terms of positioning, feeding readiness, social work. Luckily, because of the size of our unit, we already did have this ancillary staff support that was already specific to our unit, but they were also part of our workflow committee as well. And then we had to think about the big thing of discharge. What does it mean to be discharged from the small baby unit? If we only have 10 beds and all of a sudden we're getting some twins, we got to think about how do we move babies around. So this was some of the other details we had to think about is when you graduate, where do you go to and what does that look like? And then of course the go live, when we were ready to go, how do we start? What do we do? And we had to think about how to bring in extra staff for that day we wanted to kick off and kind of slowly move babies around to implement that small baby program. So this was a lot of work on this committee, and we're still working today. So the guidelines committee, this was probably something that we almost had in a nice little package. At Texas Children's, we are very fortunate that we have a lot of our providers, multidisciplinary providers, that put together the Baylor guidelines that come out every single year. And this is what we use to practice by. And so we didn't want to reinvent the wheel. We had it. What we needed to do was tincture out all of the specific care for those patients in that population and kind of put it together in one little piece. And so everything was together instead of having to go to this chapter, this paragraph, this chapter, this paragraph, putting it all together. And again, that was a really nice reminder for everyone that, hey, we really do need to be consistent. We have it there. We need to make sure that we're practicing all the same. And so some of the things that we had, and we did have partnership with both medical and nursing as well with these committees, because it wasn't just patient care, it was also bedside care. What does the admission process look like? What does the daily care process look like? We talked about delivery room management, and of course, respiratory, cardiovascular support, neuroprotection, FENGI, infection, and as well as the big component was our parent piece. We knew that we were really wanting to be more neurodevelopmentally appropriate and sensitive, and kind of we're talking about maybe changing, touch times and everything, but then we also had to remember, what does that look like for that family? So now that they have the small baby, are we reducing their interactions? And also kind of making sure that we're partnering with them and teaching them how to best support their infant. Some of our nurses put out a really nice simulation video about kangaroo care and how to do a standing transfer. And so that was one way that we made sure that we were partnering with our families, that so even though this baby is small, we still know the importance of that parent-infant bond and that we want them to interact. And so that's a nice little simulation video that we kind of brought it together, that even though this baby is very fragile, we know the importance of kangaroo care, and that these parents are watching this video so they know how to support their infant throughout that transition from being in the isolette into the mom's arms. So the education committee, I would say they probably had the most fun. So this was, again, multidisciplinary. This unit could not have been created without multidisciplinary care. So this committee was composed of nurse practitioners. We had a couple of MDs, we had nurses, we had our educator, and we had a CNS. And what they were tasked with was pulling together all of the guidelines and developing education. Because again, we knew, we might know the physicians are aware of the Baylor guidelines, but are the nurses aware of the science behind why we do what we do? And so we wanted to make sure that when we were coming up with this presentation, it was applicable for all levels. And so this group was tasked with developing a multidisciplinary session. We decided to make it 4 hours. It seems like a long time, but there's a lot of information to cover in this. And so it was 4-hour sessions we put together at Go Live. We, I think, went over about 3 weeks, and we went 2 to 3 sessions. Multiple times of the day. We had them morning, afternoon, and evening to get all shifts. If you were a nurse, an RT, PT, OT, social work, nurse practitioner, fellows, physicians, if you were caring for babies in this unit, you attended this class. And we're still working on some ongoing education. It just didn't start with go live. We're constantly revamping and giving more education as we're getting new providers and new nurses who want to be a part of it. So this education did not stop when we opened up the unit. It is continuing to occur. And so we all know mandatory education, it's super exciting, right? We all love it to sit in a room together for 4 hours. And as we saw the sign-up list, I could hear the grumblings of even my staff. What are we gonna do for 4 hours? And so we really wanted to make sure that we were being interactive and we were capturing our audience. This wasn't by discipline. All groups worked together. And so we did it didactic. We had some, slides, PowerPoints. We did simulation videos. We created a little simulation video based on some of the new concepts that we wanted to introduce for delivery room management, really partnering with our OB and talking, having that good communication with the OB prior to delivery, making sure our room was set to the right temperature, talking about delayed cord clamping. We want to do this. Are there any barriers that are going to prevent this? And also, the only really new concept we introduced was the concept of a pre-brief. Coming together, all members of the team who are going to be going that to delivery and talk about what are we foreseeing? What is everyone's specific role? This is what we foresee. We're going to do CPAP first. We're going to do X, Y, Z. You do this, you're going to do this, you're going to do this. Does anyone have any barriers that we can see right now based on the information that we've received from our OBs? And again, so that was just one way to kind of break everything up. And we did some interactive games. We have a really very creative respiratory therapist educator that put the respiratory session into, it was a Jeopardy-style game up here. And so she has a memory like no other. And so if people weren't, interacting, she'd call people out. Okay, you've got oxygen for 10. And the question would open up, and if you didn't know the answer, you could ask phone a friend. But again, it made it a little bit more interactive. None of the information was new. It was information from our guidelines. And so people were just like, oh, okay, I do know that. One of my favorite sessions that we ended with, which kind of put everything together, was the Mythbusters. I don't know if you ever watched the show, but two of our newer physicians put this together. And what they wanted to do is, everyone always hears about this urban legends of, this led to this babies, this led to this. And we really wanted everyone to know the science behind our practice changes. And so we kind of got an idea of what the most common myths were, and with a lot of these patients, and essentially we either proved them or we busted them. And it was very eye-opening because I think some of the topics we talked about were things like extubation trials leads to IVH, reasons for anemia, delayed cord clamping, pre-medication for non-emergent intubations. And so again, it was giving the evidence as to what was driving our practice. And I think that really hit home for a lot of our bedside staff as well, knowing the why behind the what and why we're doing it. So outcomes and compliance. So again, this was something that started off as kind of one big large group, and then we kind of realized, wow, we're tracking two different kind of things, and we need to split up into two different groups. What's really important is you want to consider, what are you going to measure? Are you looking at just physiologic data? Are you going to look at stuff as just like temperature, heart rates, blood pressures, saturations, and also as well as infant outcomes? You really want to know, this is probably something I could say, start from the beginning. Know what you want to track and measure, and know that from the beginning. How are you going to get the data that you want, okay? It could vary from organization based on the gaps that you find within your practice and what you look at based on your own data. And also, how are you going to measure it? I mean, most facilities are now on your EMR. I can tell you from doing chart audits, it's painstaking. And that's something to think about, is how can you get the data? Are you able to pull your data in from your EMR, from Cerner, from Epic? Can you pull data from your monitors, from sickbay? Okay, you have all the data. How do you make sense of it? Because it's a lot of data. And you have access to statisticians who can help you correlate that data into something meaningful and relate it back to your outcomes. And so, and the other part of it was we started realizing, well, that's really not outcomes, that's compliance. Is how do you track your adherence to these guidelines? How do you know, is everyone doing what they said they were going to do? And so that's what the compliance committee kind of took out more, was looking at adherence to our guidelines and our protocols. So talking a little bit more in depth about these last two. So the outcomes committee. So one of the big things we wanted to look up, like Kellie had said, was our infant outcomes. And so what we already are doing is we're looking through, we started with our VON network database. And so we looked at those composite measures. And what specifically we're looking at is our chronic lung disease rate, our severe IVH, so that's, IVH grade 3 or 4, our necrotizing enterocolitis rates, ROP, pneumothorax, late onset infection, and then of course your mortality rate. And so those were our big outcomes, is because we have that data from years past. So we know that's already there. We already report that information. We don't have to reinvent that wheel. It's already based on infants less than 1,500 grams, and we can go through and tincture out and get those smaller, less than 28 weeks and less than 1,000 grams. So that's what we used for our outcomes. The other thing we really wanted to look at, and which was in a lot of the literature, was the evaluation of resource utilization. So such as, are you reducing your number of chest x-rays? Are you reducing number of unnecessary lab draws? You're having the same providers care for these patients. They're doing consistency in care. Are we able to reduce that overall resource utilization? Family satisfaction is huge. We wanted to see, are we making a difference? Are these families, now that they're being cared for by a consistent group of providers, they're maybe cohorted in a location that they can talk to other families that are going through possibly the same diagnosis, the same complications. They have that relatability. How do we measure that? The big thought early on was we're going to give them a survey. We're going to give them a survey right before they leave, they graduate small baby program. We came up with a nice little list of questions, but then we found out we couldn't give it because it matched the Press Ganey. It was too similar, and you can't really give the same survey twice. So that's still a component that we're still trying to work on in terms of how can we gauge our family satisfaction. And the other part is also staff satisfaction. How are the staff feeling now that we are having all these babies kind of cohorted in a location that they're, having all this? And that's another thing, too, that was in the literature, is that, the quality of the care and the team collaboration was going to lead to higher staff satisfaction. So our compliance committee, they just kind of gave me this information. It's one of the committees I have not been able to be a part of because I'm on so many of the other ones. When they started, they had a list of about 10 items they were looking at. And they realized, wow, we really are having a hard time getting all of that. We need to focus on what's the priority. And again, they went back to where did we feel like we needed to where we needed to improve. And so they really focused on these things that are listed up here. So discontinuation of PICC lines. And of course, we know that we always want to reduce our CLABSI and our thrombotic events. And so are we taking our lines out when we say our goal is at 120 of enteral feeds? Are we doing that? We've gotten really good about, this baby has not tolerated foods in the past. Let's wait another 1 or 2 days. No, people are holding us accountable, and we're going back to make sure, are we doing what we said we did? Antibiotic initiation. This is to help, improve your infant morbidity and mortality from sepsis. From the time that our antibiotics are ordered, are they getting to the bedside and are they being administered within 1 hour of life? This is from from admission and also your late onset sepsis. And this is something that is not just at the provider level. You have to talk to your pharmacy colleagues as well, making sure that they have the staff and support to be able to get those antibiotics down to you as fast as possible. For humidity, we know how important it is for these small babies with their thermoregulation and their electrolyte balance as well. Is our humidity being initiated and maintained at 80 to 85% for the first week? So the top down. So that's something we deliver our babies up in a floor above us, 4 or 4 floors. It just depends on where that mom delivers. And so are we getting this baby into their isolette with that top down within a reasonable amount of time? Because that was something that was always one of the biggest concerns based on our nurses, is that the top is up for so long, or then it comes down and it goes back up, and it's, we're bothering these infants so much. And so they kind of came up with this new goal, is to have that top down within 1 hour of life, or only up 1 time or less within the first 6 hours. So that would be your instance of this infant comes without umbilical lines and you need to put umbilical lines in. So, okay, the top is down, you put it up real quick, put your lines in, and it's closed and it's done, and you leave them alone. And then, of course, our shuttle use. I don't know if everyone heard of the shuttle, the GE shuttle? Okay. So we wanted to make sure that we were using this for all of our non-emergent delivery room resuscitations, just because of how laborious and cumbersome it is to set up. It's a great tool, but it does take time. You can't just go up and set up in 10, 15 minutes. But we want to make sure that when we have this baby, this 24-weeker that we know is going to deliver, it's non-emergent, we have the time, that we are using this shuttle, so we're not having to move them from a warmer, put them into a transport isolate, taking them out of that transport isolate, putting back on the warmer, that we're reducing the amount of times that we're moving these infants. And so the goal is that the bed that they're resuscitated in is the bed that they're going to be in upon admission. So this was one of the timelines that we kind of presented to our staff. If you go out, one of the big articles, and we'll put it up on the at the end here, is the Morris group out in California. It took them, I think close to almost 18 months to start their small baby unit. And so you can see from this timeline here, we got our unit up and running in very few months, because a lot of the background work was already there. We just had to put it all together. The guidelines in some papers, it takes 6 to 8 to 9 months. We already had that. So that was a piece that really kind of helped. It was just putting everything together. So we started in December of 2018, and we launched February 27th of 2019. And a lot of this is still ongoing. We are still revising our guidelines. We're still redoing our education. Workflow is still meeting. All of these little subcommittees are still meeting to say, are we still doing what's best in our evidence-based practice? What do we need to change and re-educate all of our staff? And so now that we've gone through the small baby, how do you graduate? And so this was our criteria that we felt that these babies were more stable in terms of their outcomes and their risks, that they could be moved safely. And so our graduation criteria is 32 weeks and 1,250 grams. And so we want to make sure that parents know this is a big celebration. It's a milestone for them. It's one of their first milestones, right? If you're delivered at 24 weeks and you finally get to have a nice milestone, you might not be ready to go home yet, but you've got a milestone. We want to celebrate. And so what we had talked about was, okay, so they graduate. What does that physically mean? Because we're only we're a program within a unit, we might need those beds. And so they will either graduate to another private room within that pavilion delivery room NICU, depending on are they still on the ventilator? Are they on CPAP that they can't go to level 2? Or are they really now a grower feeder and they can go to our level 2 NICU? So there's a couple different areas that they can go to in our step-down units. And then, of course, something that we wanted to make sure is that we're doing a very complete handoff to the new medical team as well, that we're giving the whole background. It's a face-to-face handoff, not just them reading our notes. That we're having that conversation for that continuum of care as well. So where are we now? Literally, we were kind of thinking about this, and we thought, oh my gosh, we're missing our 1-year celebration. We're missing cake, but we got pretty good desserts here too. So literally today is our 1-year anniversary of opening, and I think we're very excited about that. Yeah. We're very, very excited. And so so what are we doing with that? We're still revising our educational content. We have our new trainees come in at the beginning of every summer. And so July, we're actually right now putting together everything in terms of what do we need to change. And not just giving our trainees the education, but going back and probably coming up with like a blitz for all the providers who've already gone through. Okay, this is what we've noticed. This is what we need to improve upon. We are still gathering our outcomes from the past year to be able to compare it to our previous years, and we're continuing to monitor it longitudinally. We want to look, outcomes take a long time. We heard, this morning it can take almost 18 to 24 months to really see a change. And so we know we literally probably, I think, beginning of this week just got our VON data from 2019. So that's something that we're about to sit down and kind of go over to see, okay, where did we go from 2018 to now in 2019? And I think we've had to date 86 babies within this population of inborn in our small baby unit. And so this was one of the really the driving articles that we used was this, the small baby unit improvement quality and outcomes in extremely low birth weight infants. And like I said, they opened up, I want to say it was in 2014. And it's a really good article, and it talks about where they were. They talk about their outcomes in terms of they did not like where they were in terms of their chronic lung disease, ROP, their overall length of stay, and it really goes through everything that they found that worked within their unit, and it's a great place to start. We also are part of the Vermont Oxford Network and Quality Collaborative. So some of the groups have had kind of some side work in terms of our extubation, CPAP first, delivery room management. So we kind of pulled from other little groups that are working within our NICU to bring it all together. And of course, we went out to the national boards. And who else out there has had small baby programs? What have you realized has been your challenges? What can we learn from? What do we need to consider? And so again, instead of reinventing the wheel, I always like to think of the motto like, steal shamelessly, but just borrow. People have already done it. I would rather someone learn from us in terms of what we found was really distressing, so they don't have to waste that 6 months on that, and they can get the ball rolling with something from the beginning. So I know we kind of wanted to give some time for any questions or comments, and that concludes our presentation.
I was wondering, one of your metrics was to look at initiation of antibiotics within the first hour, I think it was. Did you look at Did you also look at the termination, discontinuing antibiotics within whatever you set, 72 hours, 24?
Yes, that was also part of it as well, was making like an antibiotic stewardship. In addition, was that if they, the 48-hour rule out, we do have in place already a late onset sepsis algorithm. So for babies that, what they do, we kind of look at, we use like different markers, we use CRPs, and in addition, we have like a nice little algorithm of what are the signs and symptoms and can we stop even sooner. So some of the antibiotics we do stop at 24 hours of life, but yes, they are stopped by 72. But the early ones, it's 48 hours rule out.
Yeah, I'm on. One, did you have a feeding protocol and was it followed pretty well? And two, were you able to improve on your BPD rates?
So for the feeding, yes, we already have a very robust feeding algorithm. Almost all of our, actually, I would say 100% of our small babies get either human milk or they get donor milk. And yes, it started right away, and we have it based out on their birth weight. Trophic feeds for it depends on their specific age and their weight, if they get 3 days of trophic feeds and then advanced. But absolutely, yes, that is something that has been. And then when we start fortifying early on, and yes, so they're pretty much up to full feeds by 7 to 10 days if they're tolerating it well. So we are literally just, we don't have the specific numbers to be able to show like a statistical difference, but we can just say anecdotal, like we know that we're seeing a lot very positive outcomes.
Hi, I have several comments, questions. Number one would be, how are you addressing the emotional needs of your NICU staff working with these very low birth weight infants? Long time ago in training, when we made NICU rounds or ICU rounds, once a week, the psychiatrist in our children's hospital would make rounds with the staff. Something like that would be important for your staff. Second item, it really relates to quality of life, because what I saw in your presentation is a huge input of dollars in order to support these babies, particularly in the first 72 hours. And so what I'm asking is there because you're tracking things, which is great. Anything that's not measured can't be changed. But is there a quality of life feedback to the dollars spent relationship? That's another question. And then maybe I missed it, but do you also run a follow-up clinic during the first year? If not, what is your handoff procedure and how are these babies followed?
All right, I'll address the first question on taking care of our nursing staff who take care of these very low birth weight infants and the stress that it can cause on them. One thing as a positive note I want to bring up that we did not expect when we opened the small baby unit is these nurses really took ownership of the babies. And if I want to say that there was one thing that I can't measure that I think really made a difference was the fact that these nurses were back there. They were very very team approach. They always helped each other. They knew those babies very well. So therefore, they were able to, it was an ownership. It wasn't like, oh, I'm gonna take care of this baby today, and tomorrow I'm over there in the unit, and the next day I'm over there, right? They're back there with these babies all the time, and it really, really did help the ownership of those babies. I think that has really improved our outcomes as well. But on top of that, we did see that was not expecting the stress that it was going to cause on them, especially on the bad days when there's several of them not doing well back there, or constant alarms, all of the things that happen when you put such a high-risk population together. We did start rounding on them regularly as a leadership team. We do have our social workers do some support groups for them as well. They, like every other week, they'll do like 2 hours in the break room. They'll round on them as well. And then we do have our chaplain round on them. And then we've got a tandem support team that can help as well. So we are caring for our caregivers, yes. Oh, yeah, so our turnover, well, I can't say just in the small baby population, but I can say for the Pavilion NICU, we've run less than 3% turnover rate in our nursing staff for the last 3 years.
Yes, we do have a complex care follow-up clinic that are babies that have multiple, like if, going home, if they have multiple, like comorbidities, that they are followed up in our complex care clinic as well. Especially if, that they have everything, all services together versus if they just need that for a pediatrician. But most of them do go to our complex care clinic.
Unfortunately, I think we're run out of time. The 2:15 will be, or 3:15 program will be starting shortly. Or is it 2:15? Sorry, 2:15. 2:15.
Okay. Before you go, I'm sorry. There's actually, we didn't make any time for you guys to get there, and because you can't get there, right this second, we're giving you 5 minutes to get there, but we're also changing out the rooms. We are? No? Oh. Or,
So Christina thinks that they're going to divide up into those two groups, and so it's okay to keep the room.
Should we keep them as is?
Yeah.
So we'll just give everybody 5 minutes.
Let,
Welcome to stay afterwards, and I know there were a couple more questions out there, so feel free to find us, and we're happy to discuss them.
we'll give you 5 minutes. We're going to keep the rooms where they are. Upstairs, there's a large number of people there, but I think they're going to divide up into the two other groups, and so I think we'll be okay. Let's give you 5 minutes for transition. Thank you. As Christina Davidson said, because she thinks that they're going to divide into those two.